give you a quick overview of some of the activities that are going on right now with eHealth Initiative in case you're not familiar with our work. eHI is an organization that's in Washington, D.C. We're celebrating our 20th year anniversary. We do education and thought leadership, really around the critical issues of the day related to healthcare and technology. And what we primarily do is convene executives to do thought leadership, and we talk about a number of important issues. This is just a sampling of some of the organizations that are involved with our work. If you don't see your organization's logo up there and you'd like to be engaged or you're interested, feel free to shoot me a message through the chat feature, and I'm happy to get back to you and talk about how you can get involved in what we're working on. Our current focus areas are pretty hot topics right now. We've been doing a lot of work around consumer privacy with the Robert Wood Johnson Foundation and the Centers for Democracy and Technology, CDT, here in Washington. We also have a major focus on virtual care, telehealth, information sharing, all of those interoperability issues that are related to sharing information virtually. We've got a large body of work around social determinants of health. Hopefully you've seen some of our recent reports on analytics and how to use healthcare data. Finally, as the rest of the industry is really consumed right now with COVID-19 and all of the issues surrounding COVID-19, as are we, and we're trying to bring to you solutions and strategies for how to use data and technology to deal with COVID-19 right now. We've had a large number of educational programs throughout 2020 this year, and this is just a smattering of some of the different topics that we've covered. I want to let you know profit. So all of these programs are available free of charge for you on the Resource Center at ehidc.org. And I encourage you, if you haven't seen these, to go on in, download the programs, watch the webinar, look at the slide sets. A lot of really fascinating speakers and experts around the nation talking about COVID, telehealth, privacy, interoperability, information sharing, all sorts of issues. And also want to let folks know we've got a really exciting topic tomorrow at 1 p.m. We're going to have results from our recent survey that we did of healthcare executives at their readiness to meet the CMS interoperability rule. So if you haven't signed up for that, I encourage you to go ahead and do that today. And then finally, I want to encourage you to download our latest work. We have 2 new reports out in the last month, one on building a modern healthcare system and recommendations from our COVID-19 federal work group. Really interesting recommendations around how we can move forward and what resources are needed in public health. And then another really interesting report on supporting American Indian and Alaskan Native communities during COVID-19 and some of the data and analytics that's going on around that community and how that can be helpful. And then we're getting ready to release another report next week, looking at the ethical use of SDOH data during COVID-19. So you can look for that report. And you can also look for our Robert Wood Johnson Foundation report in December of this year. So feel free to visit the website and download that information. And finally, I really want to thank CAQH for sponsoring this program today. We are a small nonprofit and we appreciate all the support we get from sponsors and nonprofits like us to help support the mission of the organization. And I'm especially grateful to Robin Thomasschauer, who's going to join us now, the president of CAQH, who's been just a tremendous value to eHI and the foundation over the last several years. Robin actually has served as a board member on our board of directors and just been really invaluable to our work, and just delighted to have her here today with us. So Robin, let me turn it over to you.
Thanks, Jen. And for those of you who are not yet involved with eHI on a regular basis, just a little pitch that it is a terrific organization and a wonderful way to learn more about what's going on across the industry and meet some terrific people who are very deeply engaged. So thank you to all of you for being here today. Very much appreciate you taking the time to be with us to learn about something that we're working on that I think is going to be very important as we look at these new interoperability regs and implementing them. So with that, next slide. Next slide. Thank you. So for those of you who aren't familiar with us, CAQH is a nonprofit alliance of health plans and our trade associations. And we're working together to create shared solutions to reduce administrative burden, particularly in the healthcare business processes. Our alliance members are collaborators in identifying pain points, between health plans and providers particularly, and in helping us to develop solutions to best meet the needs of the industry. Our initiatives fall into these three buckets you see on the slide here: explorations, core, and solutions. The explorations team is our research arm and particularly is focused on the annual index report, which I know a lot of you are familiar with. Those of you who aren't can find it on our website, caqh.org. The index annually measures the transition from manual to electronic administrative transactions specifically, and highlights the potential savings opportunity as adoption and efficiency grow. Core houses our operating rule development and certification program, and Solution handles the development and maintenance of what we call our industry utilities, collaborative initiatives that address provider data management and industry business process issues, for example, coordination of benefits and credentials verification. Next slide. This looks very much like the slide that Jen put up a few minutes ago, and it's because, like eHealth, we work across the industry, partnering with stakeholder groups, payers, providers, state and federal government, vendors, standards organizations. We participate in a lot of industry boards and committees, and what we are working to do is gain a perspective on the broad industry landscape as we think about the kinds of work that we're going to do. With our partners, we work to develop industry standards, conduct research, develop technology solutions with the goal of eliminating business inefficiencies, reducing costs, and importantly, increasing access to care. Our newest solution, the FHIR Payer Endpoints Directory, is what we'll be discussing with you this afternoon. And with that, I'd like to introduce April Todd, our Senior Vice President for Core and Explorations, who's going to begin this discussion. Thanks again for joining us today.
Great. Thank you, Robin. Can we move to the next slide, please? And the next slide. Well, good afternoon, everyone. As was previously mentioned, we want to talk with you today about the FHIR Endpoint Directory and show you a cool little demo as well to help you understand what the directory will do. But before we do that, I wanted to provide a little background on how we got to where we are and a bit more of what we'll be discussing today. I'm sure many of you are familiar and probably very familiar with both the CMS and the ONC interoperability rules that were passed or were finalized earlier this year. Really those two interoperability rules are intended to help patients get greater access to their healthcare data to both make better decisions and also to improve care coordination. And one of the key foundational elements of those rules is to use FHIR-based APIs in order to provide patients with access to that information. There are two components of the CMS rules that are of most relevance to what we'll be talking about today. There is a requirement around permitting patients to get access to their healthcare data through third-party applications. This is a requirement that is enforceable in July 1st of next year. There's also another requirement that is effective and enforceable on January 1st of 2022 that also requires the exchange of data between plans at a patient's direction to help with care coordination. So for a patient for 5 years back, the health plans that they have been affiliated with need to be able to share that information with a patient's current health plan at their request to help coordinate their care. As patients are giving permission to share this information to help them get greater access to it, there are also some requirements in the rules that that encourage health plans to provide their members with information around how to best protect the privacy and security of that health information that is being exchanged and being made available through third-party applications. So with this as background, as these rules were coming into play, there was an organization at ONC called the FHIR at Scale Task Force, including a number of industry experts, as well as those that participate with the Da Vinci Project and other organizations and experts in the field, that identified that the ability for all of these organizations to engage with each other was going to have some challenges. And the FHIR at Scale Task Force in particular identified that an endpoint directory would be a critical solution to overcome some of these scale barriers. So, based on all of this work, CAQH started from the foundation that many of these organizations were working on in terms of recommendations, and have been working over the past year to engage with the industry and see how we could be helpful in bringing an industry solution to the table to help address this barrier to scaling FHIR adoption. If we can go to the next slide, please. So the particular barrier that I am specifically speaking about is really just the volume of connections that will need to be made across the industry to facilitate really the broad adoption of this rule. So if you look at all of the different plans and Medicaid agencies and app vendors that will need to share information with each other, this really could be connections that are over 300,000 different connections. And these are organizations, many of which may not be familiar with each other and may not have to share information all that frequently, but do need to be able to share information. So the ability to trust those connections is extremely important. And what I mean by trust is, being able to trust that there are privacy and security provisions that are in place, that organizations are conformant with different standards, that they are able to share information with required use cases that are referenced in the rule, and also that there are specific technical frameworks in place that will help to facilitate this exchange of data. So really with all of these needed connections that need to occur, having to do this point to point could create a significant administrative barrier for industry participants all across the country. So we can go to the next slide, please. So one of the things that we have been doing over the past year is engaging with industry participants to help to understand, what is needed to facilitate these connections at scale. And what we've heard from the industry is really there is a need for a payer endpoint directory and a registry of applications to help organizations connect with each other. And so what we have heard and what we're working on and what we'll see a little bit of later today from Ron is a solution that does a few of the following things. So one, it would allow payers to share information about endpoints, including capability statements, and help to really simplify and automate some of those more manual processes. It will also allow third-party applications to upload information about themselves and make that information available to payers. It would allow payers and third-party applications to query payer endpoints for multiple use cases, and to do this in a couple of different ways. To be able to do this through a portal for those that are ready to do that through that mechanism, and also for those that are more advanced to just be able to do this in a fully computable way through APIs. This solution also will validate the identity of all the participants, both payers and third-party applications in the directory. And it will seek to, in helping to make those trusted connections, it will confirm privacy and security attestations, look at different components of the privacy policy and data use agreements as well. And also ensure conformance testing and validation of FHIR endpoints and the ability for those organizations that will connect with each other that they can work with those endpoints. And then lastly, facilitate the connection request between these organizations to really help facilitate the connection needed to actually start to exchange information. So if we can go to the next slide, please. So the way in which we have been doing this is is a very similar pattern that CAQH has employed over the last 2 decades. As mentioned previously, we are a nonprofit organization. We bring together industry experts and participants to reach consensus on how to address a particular issue and an item. And so really we have a strong governance structure to bring participants together. We bring working groups together. We have a work group of health plans today that are working on some of the nitty-gritty details of how to operationally make this work. And we bring solutions to the industry that are shared, and that really is a place for, particularly in this instance, one trusted source of information that organizations can utilize it and trust will be accurate. Can we go to the next slide, please? And so wanted to also lay out a bit of a timeline in terms of the work that has been done and the work that is upcoming. So I think many of you are aware of when the CMS proposed rule was put out back in 2019. There has been a lot of work that has been done within the industry, both before that rule was released as well as after that. Work from HL7 and Da Vinci, also work from the Karen Alliance. ONC FAST has done a lot of work in this area. And really the work that we have been doing is really building on all of these great industry efforts to help operationalize something that can really serve what is needed within the industry and address some of those barriers. So we started working on this earlier this year. We have been working and testing things at Connectathons through the March through August timeframe, and just announced in October that we would be working with organizations to really bring this to the industry in a production format, which we are looking to do at the end of Q1 of next year. So that organizations we can help facilitate organizations' compliance, both with the requirements in the CMS rule that are enforceable on July 1st of 2021 on the Patient Access API, as well as the payer-to-payer data exchange that has an effective date of January 2022. So we can go to the next slide, please. So with this as background, I want to introduce Ron Erwang. He's our Director of Strategy and Innovation at CAQH. He's going to talk a little bit in more detail about the use cases that the directory is intending to address and some of the challenges and barriers that we have been working through. And also we'll be doing a pretty cool demo to show you some of the work that we've done to date. So Ron, I'm going to hand it over to you.
Thanks, April. All right, so I'm going to try to bring to life and illustrate the problems that would occur, some of the barriers that April had mentioned, as health plans and app vendors try to connect with each other in the absence of an endpoint directory. What does a world look like if an endpoint directory doesn't emerge and is not available for these organizations who are trying to take advantage of the data that's available and also comply with the CMS interoperability rule. And then after I've had a chance to explain the problems and bring those to life, I'll also give you a demonstration of how an endpoint directory could streamline and solve these problems. So we'll start off with the first challenge, and this is really in reference to the requirement that April had mentioned around payers being able to connect with one another per the 2022 requirements of the CMS interoperability rule. So imagine, I'm Ron, I'm moving from one health plan to another, from health plan A to health plan B. Health plan B wants information, patient and other information that I had within health plan A for a multitude of reasons, for continuity of care, to make sure that I'm not getting redundant tests in my new scenario that I had already gotten done in my first scenario. So lots of good reasons why health plan B would want data from health plan A to ensure those things. So as I'm moving from Health Plan A to Health Plan B, Health Plan B would need to connect with Health Plan A to collect all of that important information. Now, what are all the things that Health Plan B needs to do to be able to get Health Plan A information? Well, Health Plan B needs to figure out whether Health Plan A even has a FHIR compliant API and where it is, what the address for that API is. So, Health Plan B has to, reach out to their contacts at Health Plan A, or, search Health Plan A's website to see if the endpoint information is there. Let's say Health Plan B actually finds that API information. Well, they've got to send a request to Health Plan A to be able to get access to that information. And, Health Plan A has to take a look at that request and, confirm that Health Plan B is who they say they are. So, that's the identity, organizational identity verification that April had mentioned. And in addition to that, Health Plan A has to take a look at all the security and privacy policies, and Health Plan B has to make sure Health Plan A has all the technical conformance. And once all of that has been established and all those check marks have been checked, then finally Health Plan A can give API credentials to Health Plan B, and Health Plan B can make that request. Now, if all of that needs to happen before patient Ron or member Ron moves from Health Plan A to Health Plan B, I probably would have gotten those redundant clinical tests at that point and probably incurred more costs for the healthcare system. So imagine having to do that hundreds of times as all of those different health plans have to connect with each other. So not only administratively burdensome, but also takes a lot of time and it results in some member and patient dissatisfaction. Let's move on to the next scenario, challenge number 2. Okay, and if you could just advance through all of them, we can build out the slide. Okay, thank you. So this is in relation to the interoperability requirement that becomes effective in 2021. And so that's the patient access API requirement, where health plans need to be able to expose patient data to members who want to be able to use it for their own purposes, so as directed by the member. However, the members may choose to interact with their data through third-party apps. So, maybe they have a personal health record on their smartphone, and they want to aggregate some of their information not only from their healthcare providers, but also their health plans. And this is a way for them to be able to do that. They'll go into their PHR app and select Health Plan A or Health Plan B, and then ideally the app vendor has already established a connection with those payers. However, let's take a look at what happens as a health plan needs to give access to an app vendor. So, the health plan needs to take a look at that app vendor and see that app vendor is who they say they are. So, organizational identity verification. Also needs to take a look at their privacy and data use policies and represent the appropriate information to the member who's authorizing it. Most app vendors are probably going to have significant levels of experience around FHIR APIs. However, some of them might be doing this for the first time. So, health plans are really interested to make sure that the app vendors are able to actually interact with a FHIR compliant patient access API or a provider directory API. So there's some education, training, technical conformance testing, and then finally, just as we talked about it in the first scenario, the actual issuing of the API credentials to the app vendors so that they can make those calls on behalf of the member or on behalf of the patient. So very similarly to the previous scenario, lots of administrative burden in collecting that information, reviewing it and approving it, and then finally issuing the API credentials. So it can take a lot of time. Imagine there are thousands of app vendors out there trying to connect with hundreds of health plans, lots of different connections that need to occur there. Okay, let's move on to the next slide if we could. So, I want to describe a little bit about what's out of scope, just to clarify what the boundaries of this endpoint directory are and what types of activities health plans and their IT departments may still have to accomplish. And then I'll talk a little bit about potential phase 2 capabilities that we're considering on working in conjunction with our health plan work group. So in terms of the out of scope items, just to reconfirm, the in scope is an endpoint directory and a registry of third-party apps, and all of the verifications and testing metadata related to those apps and endpoints. However, the collection of patient authorizations and consent, the actual issuing of the client IDs and secret keys, and any of the transmission of the patient data, that's actually handled by the health plans themselves. We provide the right information to streamline the connection request that goes from an app to a health plan or from a health plan to another health plan. But after that's done, the health plan would take the subsequent actions of issuing the API credentials and actually routing and responding to the data. So just to clarify what the boundaries of the solution are. And then in terms of capabilities that we are considering for the future, there are many emergent trust frameworks that are evolving within the industry. However, there is a lot of desire, as we're talking with our health plan collaborators, of establishing a formalized trust framework to facilitate the connections between the health plans. There's also a desire for more automated downstream dynamic client registration so that these connection requests can be responded to in near real time. So emergent protocols are evolving around that, and this endpoint directory is a building block that will help enable that type of use case. There's a lot of interest in provider endpoints as well, health plans being able to connect to providers and vice versa. So this platform could help address that if there's a need for that moving forward. Okay. Also some interesting opportunities around patient matching and identification of prior coverage. CAQH has some data assets as it works with the health plans to be able to enable that. Okay, let's move to the next slide. We're going to flip back to what is in scope for 2021 as we're launching the solution. And I'm going to go ahead and share my screen right now, just so that we can take a look at the live demo. So I am logging in as a payer. Let me try it again. Okay. So I'm logging in as a payer, and then what I'm going to show you are two things, pretty simple. Entering information about myself as an organization, entering information about my endpoints that third-party apps or other payers would access. And then I'm going to show you how to query this endpoint directory for other payers' information. Okay, so this is really revolving around the 2022 requirements of payer-to-payer data exchange. So imagine I'm a health plan. I'm entering some useful information about myself, contact information, administrative contacts, and technical contacts. But the real substance of this is around the endpoints. Let me just hide my screen real quick. Okay, so let me go ahead and click this. I can show you some of the endpoint information that is available as you're entering it, and these are the same information that you would get as you query it. So you want to clarify the use cases these API endpoints are solving for. So there's patient access, there's provider directory, there's payer-to-payer data exchange, prior authorization formulary. You can enter information about the FHIR version, whether it's a test endpoint or a production endpoint, the authentication method. So all of this information that a consumer or a requester of the API would need to be able to connect with it. Okay, and then let me go ahead and show you what it looks like to query it. So let's say I'm one health plan and I'm looking for another health plan's endpoint, and perhaps I'm looking for their payer data exchange endpoint. So this is the same information that I've entered about my endpoint, but belonging to another payer. And I've got their URL and the use case, authentication method, and the FHIR resources supported. And then I won't show this to you right now, but all of this information that is entered as well as queried via portal all of this is also available via API. So a programmer could program the querying of this endpoint directory and fully automate the acquisition of this endpoint information to further streamline some of their downstream processes. Okay. Let me flip back to the slide deck real quick just to finish off the demonstration. The last thing that I want to show you, so I just showed you how a payer would enter their endpoint information and query another payer's endpoints. What I want to show you now is how a third-party app would register their information and how a health plan would find that information as well. So let's say I have a company called DocFind LLC. It obtains provider directory information from health plans to be able to support their members so that they can find the care that they need and be able to book appointments. So what I've done is I've entered all the relevant information about my app here. So very similar to information that you would post within a Google Play Store or an Apple App Store. Your version, some screenshots, a description about what your app does and what it's useful for. So good contextual information that a health plan, if they wanted to publish or provide information about this type of app on within their app store, they make available to their members. All useful information that they could post to that type of environment. But here's where it gets interesting and has the most opportunity for streamlining. So, every health plan has their list of privacy and security questionnaires and technical conformance tests that they would like every app vendor to run. Wouldn't it be great if we had one set of questions that all health plans could align on, and one set of technical tests that could be performed on the app so that that doesn't have to be done redundantly, because that's a lot of overhead to have to do that so many times for all of the health plans, and for the health plans to have to take part in that activity so many times across all of these apps. So what we've done here is we are using a set of questions, leveraging some industry standards around privacy and security. So we're leveraging many of the questions from that CMS has used around their Blue Button initiative, the Karen Alliances used as part of their code of conduct. And we're also collaborating with our health plans to make sure that these are the questions that they need to be able to streamline that downstream process of onboarding an app vendor. So just a subset of the questions, but we're just trying to make sure that we have all of the right information that a health plan needs to be able to present to their members. And then in terms of technical testing, we just want to make sure that these third-party apps can actually integrate with a provider directory API or a patient access API. So we run them through a series of technical tests where we give them a test environment with FHIR compliant APIs, and they can check to see if their app can in fact authenticate against a patient access API. They can query patient RONs information from a patient access API and present all the clinical results within a within their app, and upload some screenshots to prove that they've done everything appropriately. So we just want to make sure that they can go through this process so that they don't have to do that 100 different times across all of the different health plans. Okay, and some more information about the endpoints that the app can connect against on the patient access side, and other tests. And then finally, once we've collected all of that important information about the privacy and security and the technical conformance, now we're ready for all of these organizations to connect with each other. So here are all the apps that are available. A health plan could check up on these apps and get the right information, also going to be available via API. And then the apps can find all of the health plans and how to connect with patient access APIs and get the FHIR versions and their authentication methods. Important here, sending a connection request. So all these players are all now within one space. Everybody knows who everybody is, can trust that everybody is who they say they are, can trust that everybody is conformant to the technical standards that have been established. And from a trust perspective, that everybody is representing their privacy and security policies in an appropriate way, and that's totally transparent and totally visible to every organization participating. So a trusted environment for all of these organizations to make these connection requests with one another. Okay. And so that's where we're at right now. We have our proof of concept that we've built from payer to payer querying. We are actively building out this third-party app registry. We're going to be beta testing all of these capabilities in December and January, and working with both health plans and app vendors on that, just to make sure everything works end-to-end across these different stakeholders. And there's a lot of alignment work that is ongoing as we speak. We have alignment work around what are the most appropriate payer organization IDs, and what's the set of questions and the endpoint use case taxonomies. Work that we are working in conjunction with DaVinci and ONC Fast as we have findings and decisions made within this environment. We'll be sharing all that information back to our counterparts in those organizations as well, so that we can help inform and provide some up-to-date statuses on that type of information. Okay, so feel free to visit our website here if you'd like to get more information or learn how to participate. All right. Okay, any questions, or Jen, could I hand it back off to you?
Yeah, that'd be great. Why don't we put the screen, can you do the stop sharing there?
Yep.
There we go. Great. Okay. All right, well, we've got a bunch of questions here, so let's just go through them here. And I'm not doing these in any particular order right now. So a question from Keneal Shaw. So is this similar to CMS's data at the point of care pilot API?
Or do you want me to take that?
You can try it.
I'll maybe start. I'll draw some similarities and then draw some differences here. So I think the intention of the CMS interoperability rule in terms of the APIs to help share patient information does have some similarities to the other CMS API. In terms of the FHIR Endpoint Directory that we are working on, I'll reiterate one of the out of scope items that Ron had mentioned earlier, which is that the directory itself is not going to be involved in exchanging actual patient information. This is helping to make connections, but it is not facilitating that data exchange. So that's one very key difference.
Great. Ron, anything to add there?
I think April got it.
Okay, one of the things that you guys mentioned was this beta test, and can you talk a little bit about how that's going to work? Are you looking for plans or guinea pigs to work on that beta testing? How's that going to play out?
Yeah, I can take that. So yeah, we are looking for health plans. So if you're interested and you think you're a good candidate for doing some testing, let us know. But we want to take it through the end-to-end scenarios. We want app vendors to be able to post their information and be able to send, go through all the testing process and make themselves available for querying from the health plans. And then, on the other side, we want health plans to be able to post all of their endpoint information, do their testing, answer any privacy and security questions possible, and then send connection requests to each other and also respond to requests from the vendors. So everything that I talked through, that we really want to see as much as possible that entire process working end to end. So we'll have a test environment where all of that can happen, and if organizations want to use their test apps and endpoints, that's totally fine.
And are you guys still taking input into this whole process and how it works? How can plans and payers get involved?
Yeah, our contact information's there, but yeah, we're happy to talk about what we've done, and we've got some nice questionnaires that we'd love to get some input on.
Great. Can you talk about, we've got a question here about how would a patient find their payer in the system, especially since there's a lot of words like Blue and United, especially that are ubiquitous? Yeah,
that's a really important question, and that's something that we're working hand in hand with our health plans as well as the app vendors on. So if you think at the most basic, if you've got a mobile health app, you can imagine the most simplistic way is you've got a drop down with all of the payer names. That being said, there's a lot behind that. If you take a look at your health insurance card, there's all these numbers and IDs and all the rest. So what we're trying to align on, or what are the most appropriate payer IDs that can be used to match to the endpoints, because a member has to represent themselves in some way to the app vendors or to a new payer, and then that app vendor, that payer has to resolve to a payer ID, and then that has to resolve to an endpoint. So all that to say, we have some good hypotheses in mind on what the most appropriate payer IDs are and how patient information can resolve to those payer IDs, and we're going to test those out within our beta and beyond.
So these are all things that are going to get worked out during the beta process?
That's correct. Yep.
Okay, and then so I guess that kind of answers the question about how an organization would prove their identity. Is it a similar issue?
Yeah, we're going to be using processes that are similar to the processes that CMS uses to validate organizational identity.
Okay, great. And there's questions for your contact information again. So actually, I'm going to ask Sarah if you could put that out through the chat box for folks. Again, that would be great. Let's get Ron and April's contact information out. Has CMS been involved in this effort at all?
April, do you want to take that one?
Yeah, I'll take that one. So we were engaged in some conversations with CMS late last year and early this year around the need for this endpoint directory to help facilitate FHIR adoption. So it's one of the organizations that we've had conversation with, in addition to Da Vinci, a whole host of industry experts, individuals at FAST. So we've been trying to engage far and wide to make sure we are getting everyone's feedback and needs for this.
Could this possibly be used for a consumer to help choose a health plan? And if so, how?
I could imagine scenarios for that, but it's maybe not directly related, but as it relates to, one of the 2021 requirements is a provider directory API, right? So health plans have to post all their providers in network. You could imagine scenarios where, patients/members want to check to see if, my favorite provider, Dr. Jen, is within network for a particular health plan. A provider directory API could help answer that question.
When do you expect you're going to be able to publish a draft of the provider directory?
Provider directory. Oh, the provider directory, the provider endpoints, or provider directory information?
I'm guessing they mean endpoints.
Endpoints. Yeah, that's something that we're working in collaboration with our health plan work group, just to prioritize what the big next capabilities we'll be working on.
Yeah, but just to add on to that part, that's one of the things we're looking at for the future, but not one of the items that would be available in the Q1 2021 timeframe. We're focused on the plan to app and payer to payer data exchange in those compliance states.
Yep.
This sounds very technical to me. Will CAQH issue the active and refresh tokens to third-party apps?
Yeah, I can handle that one.
Okay.
So that's one of the out of scope items. So we'll take it right up to the issuing of the tokens. So we want to give the health plan as much information as possible to be able to make that decision to issue a token, but we won't do the actual issuing. That's on the health plan or their technical partners to be able to do that.
Okay. Is there going to be a cost to access the directory?
There will be a nominal cost that we're working through right now, but we're trying to minimize the barriers to adoption, so it's going to be very economical.
Okay. And what about to be listed in the directory? Will you have to pay for that?
Yeah, go ahead, April.
Sorry. So that's one of the items that we're working through is how do we financially support the directory so that it is available for everyone to use. So we're working through some of those details right now on how to support that and what it needs to be paid for and what does not.
How about for providers that are out of payer networks? Are there any options for them? So specialists that are not on many plans or direct addresses for doctors to exchange, how could a provider find a provider without knowing the payer for the provider directory?
That's a good. So a provider who's out of network trying to find another provider.
I think so. That are not in a plan. Yes.
So I think this one, Ron, is probably related to the provider digital contact information. That is also a component of the rule. As we mentioned before, this isn't necessarily going to be something that will be in the phase 1 of what we're working on, but we are engaging with folks to see if we could be helpful related to provider endpoint directory components into the future, but not something we're working on right now.
Is there anyone managing the equivalent effort on the provider side and registering third-party patient apps to get their clinical data?
I'm not aware of any parallel initiatives around that.
That's interesting.
Other than the digital contact information for providers is something that is being recorded on NPES, which is the CMS's provider
That's right. Yep.
directory information, and it has information around their NPIs, and that is collecting that information.
Can you share any data about how many payers have already signed up to the data exchange at this point, or is this still kind of in the initial process?
We have around 10 collaborators whom we're working with to collect feedback and sharing designs. That's kind of the stage we're in right now.
How involved have the companies been in this effort directly? And I know, April, you led a couple of work groups, so I'm assuming, could you talk about that a little bit? How the plans have been?
Yeah, so Ron's pointing around the plans that we're engaging with. We're engaging them in a work group process that is fairly common to CAQH, where we bring everyone together into that work group and kind of lay out, here are the things that operationally we need to work through, some of the nitty-gritty details of what would you all like to see. So when we bring them together, we are asking them, detailed questions around, what kind of IDs can you support? What kind of, IDs from a health plan level would you like to see? And so we do surveys and straw polls, and we also, bring them together and show where there's consensus and where there's not consensus, and try to get everyone in the work group to get to a standardized way of doing things so that we can reduce some of the burden that would exist, and there doesn't need to be 50 different ways of doing this. So that's the purpose of bringing everyone together, is to get something to a standardized level that everyone can work with.
Ron, you look like you want to add something. No?
I was just reading through some of the other questions. There's some good ones there.
Under what situations or circumstances could payers reject or revoke access to third-party apps? And would that change in the new directory?
It's a good question, and I think it's important to go back to the actual CMS rule on interoperability, because if a patient is directing an app to get data from a health plan, then the rule says that only in very limited circumstances a health plan can actually reject, and that's only if granting access to the app results in security, like an imminent security risk to the health plan. I'm not sure of the exact language here, but that was the gist of it. Now, when we have information about the data use and privacy policies that we're collecting about apps, and we're getting all those attestations and the tests and presenting that to the health plan can use that information to present to their members, and they can say, hey, I've checked all of this information. I really trust this app. Or they can also say, I don't have all the right information for this app, or they say they're selling their data to another company, and I just have to tell you. It's still your decision to make, but I have to tell you that. So I mean, that's how we're thinking about it, and how the health plans were thinking about it.
So just to confirm, there's a lot of questions about this member identity verification. So under plan to plan, can you talk about again how that works? Does the new plan have to verify the identity first, and then the old previous plan have to do that? Or does the new plan pass along member identity through Open ID Connect? Maybe walk through that again, Ron.
Yeah, in the context of payer-to-payer exchange, member ID verification is important. Now, let me just caveat this by saying that right now our endpoint directory is not going to handle this part of the work. We'll be providing the right endpoint information to those payers so that they can make that connection. Now, when a patient is actually authorizing payer A to give information to payer B, member ID verification and member matching is super important, just to make sure that those two health plans are talking about the same member. I'd have to go back into the rule and see if where the responsibility remains. April, I don't know if you know that, but it's an important part of making sure that they're talking about the same members, so that PHI isn't leaked from inadvertently.
Yeah, and what I'd add on there is what is in the rules, that it needs to be at a patient request. So a patient does need to make that request to their health plan, which can be in a few different ways. And honestly, there is work going on within the industry today as to how to do that verification and what information needs to be part of that. It's not something that has been fully worked through yet, or is specified at that level within the rule.
Can you talk about, is this going to sync with the Karen Alliance app marketplace? Could you also talk about any other partnerships you're working with, or networks like SureScripts?
Yeah, around Karen, I did mention as part of the demonstration that we are leveraging a lot of the questions as part of the Karen Alliance Code of Conduct. So we have been in discussions with them about how we can piggyback off of each other's work. There certainly is some opportunity if an app has attested to the Karen Alliance Code of Conduct. There's some possibility we could represent that appropriately within our endpoint directory and app registry as well. So it's something that we'd like to explore.
How about member data? Can it be matched across the multi-payer, multi-employer, multi-provider environment?
It's something that is a possibility in the future. As the previous question around member matching, I think kind of dovetails into that. Now, we won't be exchanging member data. However, we have some interesting data assets that help support the identification of coordination of benefits. We have a solution called COB Smart that overlaps and identifies membership overlap between payers. Now, that could theoretically be used to help with member matching as part of these use cases as well. So it's also another interesting possibility that could be pursued in the future.
You guys, there's a lot of questions here. I'm wondering, still left to go through. I'm wondering if we could send these out maybe as an FAQ Q&A to folks, April or Ron, afterwards, because we do have everybody
Absolutely.
information. So because we're out of time, what I'm thinking I'll do is I'll give these to April and Ron, and then we can send them out to everybody as well, because I know there's a lot we didn't get to. So if you have any more and you want to enter them in right now into the Q&A, please do. So there is actually, April, someone who's interested in a job and people want to know if you're hiring right now. So there's definitely a lot of interest in your organization and in doing this work. So sure, they would be happy to entertain whatever. So thank you. All right. Well, we are actually at the top of the hour, but I do want to thank, this has been incredibly interesting. We've gotten a lot of top comments here from folks. Thank you. This is a great webinar. Thanks. This is helpful. So I really want to thank CAQH for doing this today. This has really been helpful to many folks, and we're not done yet. We will get these Q&As out to everybody as soon as we get this back from CAQH, and we will give you this information. Really important topic today. Thank you, April, Ron, and Robin for joining us.